Just hang in and hopefully can pay attention because the next talk's an important, I'm sure going to be a great one. It's my honor to introduce Sarah Hopkins, a colleague from the Children's Hospital of Philadelphia, who's going to be talking on a topic that's gained a large amount of national attention over the last 6 years, acute flaccid myelitis. So, Sarah.
Thank you so much, Ben, and thank you to Sandy and the Siegel Rare Neuroimmune Association. I do love the new name. I think that's wonderful. I always love coming to this meeting because it's always a great time to discuss ideas and projects and meet families, and it's just always a real delight to come. So thank you so much for having me. And do I have slides? There we go. I need to use the buttons and not the mouse, I see. All right, so we're gonna talk about acute flaccid myelitis, and I'm excited to do this, not just because it's kind of the new thing that's in the news lately, but also because I think the AFM story is really becoming one of multiple groups working together towards a common goal. And I think that's what's going to be needed because AFM is such a rare disorder, to think about what's ahead in terms of what's best for us to do for our patients, how we talk to families about outcomes, and how we can hopefully prevent AFM in the future. I really want to use that mouse. All right, so my disclosures, I do receive some salary support from the CDC, and that's for consulting related to surveillance for AFM. I will talk a little bit about surveillance at the end of this talk, and I just want to say I'm solely a consultant. I am not speaking for CDC, but Janelle Ruth is here to answer questions tomorrow. So what we're going to do today, I want to briefly, I also want you to know I did set the timer on my watch, so we will get to break at a semi-appropriate time. So if it goes off, that's why. I'm not getting a text. We'll briefly review the clinical presentation points for diagnosis. I'm actually really glad Dr. Sweeney reviewed those cases because that helps in some of the discussion, and I don't feel bad about not including the ones I was thinking about anymore, so that's great. Thank you. We're going to talk about diagnosis, risk factors, etiology, and outcome. It's going to be a little bit of a whirlwind. I'm going to focus I'm going to show you some of the data that we have from CHOP, but also talk about some multi-center projects that we have that are ongoing. We're going to talk a little bit about some of those challenges we encounter in surveillance, and then things that we need to think about moving forward, and some plans that are in place for upcoming projects. So thinking about AFM and the scope of the problem, this is the graph that you'll find on CDC's website. The most recent one, and if you look at it, these are the 584 cases that have been ascertained since surveillance started in August of 2014. You see that really the highest peak here is in 2018. We had 235 cases in 2018. 584 cases total. And I want to point out that while there were more cases in 2018, we don't necessarily know that it was occurring more in 2018 than it was occurring in 2014. What is a strong possibility is that we are just looking for it more and people are more aware of it. I think in 2014, we had 5 cases come in the course of a week. I happened to be on service. And, so it wasn't until the first one, we weren't sure. The second one, well, this is getting a little strange. The third one, by third, fourth, and fifth, we got pretty good at figuring out what was going on. When you look at spinal cord anatomy, Dr. Greenberg and Dr. Sweeney both spoke a little bit about this, where the involvement is in the spinal cord determines what kind of symptoms you're going to have. And so, of course, the yellow is the anterior horn cells. And Dr. Greenberg didn't use his wire analogy, so I'm going to use it quickly. So when you think about the spinal cord and the anterior horn cells, you've got the first nerve that has the first wire coming down from the brain, and that connects to the second wire that goes out to the different parts of the body. And those two wires connect in the anterior horn. So when you have something that's affecting the anterior horn cells, that's affecting that second wire, or the lower wire. So that's what we would call a lower motor neuron injury. When you have something affecting the first wire, the general thought there is that you have increased tone in your muscles, you have increased reflexes, you have spasticity. And then when you have something that's affecting that second wire, you've got decreased tone, decreased reflexes, and that extremity is more floppy. When we think about acute flaccid myelitis, so what does that look like? So with AFM, you've got the acute onset of flaccid paralysis of one or more extremities. This is usually in the setting of a febrile illness. So, and sometimes that means you had a fever, the fever got better, and then within a couple of days, you got this flaccid weakness. But we find actually in a lot of our kids, they've still got a fever when they come in to see us, and we'll talk a little bit about that data. AFM is nearly always asymmetric, so meaning, there's almost always one extremity that is affected more than others, and it's usually the extremity where their weakness started. So if a child comes in, is starting to have weakness in the right shoulder, may progress over time to be whole body weakness, but almost always that right shoulder and right arm is going to be the extremity that's most affected. When they come in, they often also have a stiff neck, headache, and pain in the affected limb, which sometimes leads to these kids being diagnosed with an injury to their arm. And of course, also in the diagnosis of AFM, we think about the MRI and having longitudinal lesions that involve mostly the gray matter of the spinal cord. As you've seen already, there are some difficulties with how you decide, oh, this is enough to call the diagnosis, this is not enough, and overlap with some of our other disorders. And sometimes we do actually see nerve root involvement with AFM that can be similar to what we see in Guillain-Barré. The spinal fluid is almost always abnormal in these patients if you check it at the right time. And we find increased white blood cells as well as increased protein in the CSF. So it's interesting, because you see the involvement of the spinal cord and you get the increased white blood cells that you would see maybe with transverse myelitis, but then you also can have some of the increased protein that you would see with Guillain-Barré, which also involves the nerve roots. Little bit more data about how people with AFM present. The onset may be more acute than we see with transverse myelitis, and it can be progressive over days. We found that some of our patients reach their point of maximal weakness within a day, but more often it takes several days for them to reach their nadir or the point where they're the weakest that they're going to get. And patients with lesions that are high in their cervical spine can have rapid progression to weakness of their respiratory muscles. And this is the biggest reason why recognizing it early is key, because we want to get to these patients in time to be able to support their breathing if we need to do that. And we know that if we want to consider trials and things in the future, thinking about different treatments, some of those will have to be given really early on. So right now we want to get really good at diagnosing AFM as quickly as we can. There are a range of outcomes. Some of our patients are quite normal by the end of things, but that's unfortunately the rare case. And then of course, we have the other end of the spectrum as well. We have some patients that are still years later ventilator dependent. And the diagnosis can be challenging. The differential, I'm not going to spend too much time on this slide because you've heard a lot about it already. Transverse myelitis is usually more symmetric, usually more sensory. Usually the MRI looks different from AFM, but our patients don't always read the books. So it's not unusual for a doctor to not know, especially initially, right, when a patient comes in, exactly what it is they have. And what we do at CHOP, at least, is that's a stage where we sit down with the families and we say, this is a really frustrating time, kind of, for everybody, because we're still trying to figure out exactly what's going on. So here are the things we're considering. Here are the points for one diagnosis. Here are the points for another. And here's how we're going to work through this together. ADEM, of course, can come with spinal cord imaging that looks very much like AFM. Although our ADEM patients are usually, we would call them encephalopathic, which means they're very lethargic, they're not waking up right, or they're having seizures or something else like that. That doesn't usually happen with AFM. Guillain-Barré is usually from the bottom down, so from the toes up, whereas AFM is generally from the center out. And then spinal cord stroke is always going to be in the differential because it can primarily affect the anterior horn cells, can be quite fast, and can look very similar to AFM. Brachial plexus injury, patients who have just one arm involved, sometimes it is really hard to know if it's a problem with the nerve that goes through the shoulder, which is generally really painful, can be autoimmune, can be idiopathic, can be post-viral, or whether there's something wrong with the spinal cord. So I think with time, as neurologists, and I know the docs in our pediatric ER, we've been getting much better at thinking about this early on. Oh, I think it can be the brachial plexus, but I'm not sure that it's not the cervical spine. And then trauma is the other one, because sometimes when you've fallen out of a bunk bed, people really examine your arm better than they usually do, and then they notice that it's a little bit weak. So sometimes trauma really brings the symptoms to the attention of the clinician, and sometimes it gets attributed as the cause when it's really not. Looking at our cases of AFM at CHOP, these are just our 2014 and 2016 cases, but I put this up just to remind me to talk about a few highlights. You'll find this kind of table in multiple papers. Average age for our patients was a little bit younger, 2.6 years, whereas typically you'll see age ranges in these populations ranging from 5 to 9. Most case series do report a slight male predominance, and our patients were 71% male. We found that 60% of our patients had fever at the time of presentation. Even when they didn't have fever at the time of presentation, and it's not on this table, but 85 to 90% of our patients had fever or an upper respiratory infection or other illness right around the time of presentation. Many patients do have multiple limb involvement. In 2014, it really seemed like we were seeing mostly kids that just had an arm involved. 2016, for whatever reason, we did see more kids with multiple limb involvement and even tetraplegia. We didn't, contrary to the Colorado cases, and when this first came out in 2014, Colorado was the place that had the most cases. They reported a significant amount of cranial nerve involvement, and we've only had one case with that kind of involvement. One thing that's being reported more on, though, is that a lot of these kids also present with pain, and we saw that, and we've also seen CSF pleocytosis in 85% of our kids. And I think those are really the main things. Again, the main pattern is always going to be the most weakness closest into the body. So, and what that looks like when doctors are examining patients, and one way sometimes that the diagnosis doesn't get picked up is that you only see it if you ask somebody to do things like hold your hands over your head or give me a high five or sit down on the floor and stand up without using your hands. And when patients are coming in through the emergency department, sometimes or urgent care, or even their pediatrician, sometimes they're not asked to do those things. So if you only test hand strength, or you only are sure that someone walks, then you may actually miss the diagnosis. So a big part of what we need to do is to help clinicians be more aware of the little specific things about the exam that they need to be doing to be sure that they pick up these cases. Not going to spend too much time on this slide. One patient had AFM, and you see the nice gray matter butterfly here. And then this patient had idiopathic TM, which actually looks a lot like the NMO slide Dr. Sweeney showed. But one reason it's so hard is that TM, as in this picture, can or is often predominantly a central cord lesion in pediatrics. And so it often does kind of predominantly involve the gray matter anyway. So being sure you're including the clinical information to tease that out is really important. So when we looked at our patients to see what areas of the spinal cord were involved, and this is, again, similar to other data sets, we found that the areas most commonly involved were the cervical spine and a little bit at the very bottom of the thoracic spine into the lumbar spine. And that observation was conserved both in 2014 and 2016. Interestingly, we only had one patient with a big longitudinal lesion, and this is all the same child here that had one big long lesion. Everyone else was either cervical or lower or both, with some area of relatively normal cord in between. One thing I often hear from other clinicians is that, well, there were some MRI abnormalities in the brain, so it can't be AFM. It must be encephalitis or something else. So we're finding that this actually is not true. We had a resident from Johns Hopkins rotate with us this past spring, and with his help, and Dr. Pardo's help, we looked at both MRIs of the brain in patients who have a CDC-confirmed diagnosis of AFM, and we looked at 55 patients, 17 at CHOP, 32 from Hopkins, actually had MRIs, so 49 patients total. And we found that MRI of the brain was actually abnormal in 53% of patients. Now, it's important to note that these lesions are almost always infratentorial, so in the lower part of the brain, not in the big cerebral hemispheres where we think about people having strokes and things. And these lesions generally look, if you see this picture at the bottom, generally in the back of the area of the brainstem called the pons, which is the middle area. You see it here and here on the sagittal view. And they generally look almost like that abnormality that you see in the spinal cord is working its way up into the brainstem. And sometimes we'll even go up into an area of the brain called the basal ganglia that's deep in the gray matter of the cord. And even though these abnormalities sometimes bring up the question of, well, there are brain lesions, could this be ADEM? These lesions look very, very different from what we see in ADEM. So ADEM is generally these big, you can't miss them, they almost look like clouds floating in the white matter of the brain. They're very big. And these are much more subtle, and ADEM just feels more like it's a process that's starting in the brain and can't involve the spinal cord. And then AFM is kind of the other way, something coming up from the spinal cord. So we know about half of patients have an abnormal brain MRI, almost always lower. And I do think it's interesting that the area most commonly involved in these brain MRIs is actually the pons, because it goes spinal cord, and then you have another part of the brainstem called the medulla, that's seems to be relatively spared in these patients, and then you have more obvious pontine involvement, and we don't really know why that is yet. So we've talked about the symptoms for AFM, what exam things can help to diagnose AFM, what imaging looks like in AFM. So are these kids getting diagnosed, exactly like we think they should be, or is it sometimes taking longer than we would like to recognize that these are kids that have a spinal cord problem? Well, like we've talked about, it's a complex differential, and we've had patients, and many of my colleagues have had patients where it wasn't recognized right away, and maybe these patients were sent home from the emergency room or sent home from the pediatrician or urgent care, and then ultimately came back. Or, like we heard earlier, even, had the EMTs come and then had to call them back. So that made us worried. That made us worried that people, sometimes clinicians didn't really know what they needed to be looking for. So a group of us got together, and this is data that was presented at the American Academy of Neurology this past May, and we're working on gathering more data from other centers. So this was a 7-center project, multiple children's hospitals, and we just did a retrospective chart review so to see if we could quantify how often these cases were picked up, how often they were missed, and if there were any clues about what we should be looking for to help educate people. So we ended up with a total of 68 patients with AFM. Average age was 4.5. Again, we see the male predominance, although not as dramatic as it was in our CHOP data set. And 60% of patients were originally given an alternate diagnosis. And I think the one that's most concerning is that in 53% of patients, in only 53% of patients was spinal cord pathology recognized. So in 47% of patients, it wasn't actually even recognized that those kids could have a spinal cord problem. And taking up to 4 visits to make the diagnosis. When we look at other diagnoses that these kids were given, there were quite a few. The most common ones were transverse myelitis, which again, when we're talking about the need for respiratory support, I'm not as worried about that one, right? Because sometimes it's not clear at the beginning, and what I really want is for these kids to be monitored closely for respiratory decompensation. But then musculoskeletal and trauma was actually as common of an initial diagnosis as transverse myelitis. And that one does worry me more, because those kids are generally going to get sent home with a diagnosis of a sprain and a splint, or a diagnosis of toxic synovitis, which is basically just when kids don't move an arm because they have some joint inflammation, and they can have a fever. But not something you would monitor very closely. And when we look at the significance, or things that are approaching significance, when only one extremity was involved, when it was only an upper extremity involved, and when there was a recent trauma. Sorry, I think it's almost falling off the screen. Those were things that were associated with being more likely to miss the diagnosis, which you can understand. So if a patient fell and is not moving their right arm, that would be your first thought, right? So I think recognizing that sometimes the fall, even if it's mild, is what brings that weakness to light is really important. So, are there risk factors for AFM? The group that I think addressed this best is the group from California who used basically the Kaiser Permanente insurance database and looked back also at their MRIs to see if they could identify the AFM cases in their group, and then take a look at things between the AFM cases and the rest of their pediatric group. So they found 28 patients with AFM from 2011 to 2016, 68% male. And their distribution of what they found and how the patients looked was that 18% had just one extremity involved, almost 40% with more than one extremity involved, and 43% actually had all 4 extremities involved. Risk factors that were significant seemed to be male, Asian ancestry, having asthma or atopic dermatitis, and also, this is one nobody was expecting, having had repeated head injuries in the past seemed to be a risk factor. I don't think we know at this point if that's a marker for something else. Perhaps there are other traumas associated with that or some other confounding factor there. So again, looking back to this CDC graph, the other thing I wanted to call attention to is that if you look at the timing of these cases, you basically see the cases increase, maybe start to creep up a little bit in July, August, and then peak in September and come back down. So, which brings up the question of what is that exposure that's going on? Well, we think the best bet is that this is a virus. So what viruses can cause AFM? There are a lot. West Nile virus is the one we thought of for quite a while. About 10 years ago it was in the news. Coxsackie virus causes hand, foot, and mouth disease, other kinds of just pharyngitis, things like that. Enteroviruses. Polio is an enterovirus, and of course presented very similar to AFM, and also adenoviruses. So what do we think is causing the increase? Well, I say this with some caution because I don't know that it's causing all of the increase, but I think most of us would agree at this point that there's a good bet that enteroviruses are a big part of this story. So when we look at enterovirus seasonality as measured in our virology lab at CHOP, you basically see the peaks August, September, October, and then goes down and then starts to creep up again in June, July, and August, which is just exactly like what we see on that CDC chart. And when we look at past AFM cases at CHOP, which we know we've had since about 2005, we were able to take those cases from 2009 on, which is when we started really looking at respiratory PCRs for our patients at CHOP, and take those and test old samples for enterovirus and enterovirus D68. So basically, my colleague, Dr. Graff in the virology lab, went back to 2009 and took about 70 patients from each year, from 2009 to 2017, and looked to see what years we had the most enterovirus. So what percentage of those nasopharyngeal swabs were positive for enterovirus D68. And then she graphed the percentage of rhinovirus, enterovirus that were typed as EVD68, and you see this here with peaks in 2012, 2014, and the biggest peak in 2016. So when we take that and we superimpose that on the number of AFM cases we've had, you see really, I think, just a striking similarity here, that clearly when you have the peaks of enterovirus D68 positivity, you have higher numbers of AFM. And this one, 2014, I almost feel a little apologetic for 2014 because that was when all those patients came in at once, and we recognized that maybe we needed to send enterovirus, but there was a time lag because it was the first time we'd seen so many of those cases together. So we actually only had one or two patients that were positive for enterovirus at all. And then we weren't routinely typing it yet. And then the others were negative. But I really think that's because in 2014, we just weren't as regimented as we ultimately needed to be about collecting samples. And we know that if you collect those samples as close to the onset of paralysis as possible, they're more likely to be positive. With the yield starting to decrease 3 or 4 days after paralysis onset, and then really you're unlikely to get too much by a week out. And when we correlate the number of AFM cases versus the percent of rhinovirus, enterovirus samples that were typed as enterovirus D68, is a very strong correlation. So, and then the other evidence for another piece of evidence, I should say, for enterovirus being a potential cause for AFM is this mouse model from Colorado, where basically they took 5 enterovirus D68 strains from the 2014 outbreak. And they found that 4 out of 5 of these strains induced paralysis in mice, that it induced paralysis pretty easily when they injected it into the mouse's brain, but that 2 out of 73, when they just had intranasal administration of the virus, then developed AFM as well. And they were able to isolate enterovirus D68 from the spinal cords of the mice and use it to infect other mice. Spinal cords showed death of motor neurons. There was some question. It seemed like if they gave IVIG early or antibodies to enterovirus D68 early, it did seem to prevent disease. And there was some question of whether steroids actually made things worse. Now, that's a mouse. It's not people by any means. So looking at the pattern of EBD68 and the pattern of AFM, there are a lot of things that still aren't clear. So why would it skip years? We don't have a good reason. You know, when it seemed like at the first year it was going to be little kids, we thought, well, okay, you know, it's that in the first year kids are getting immunity from their mothers, you know, and then that those antibodies clear out and then they're more prone to it. So maybe that's related, but we really still don't know. And we're amassing additional data even that enteroviruses are the cause. There's this new paper referenced here from California that suggests that, or that found that we can find antibodies to enterovirus in these patients. So looking at treatments and outcomes, we basically use all the traditional treatments for myelitis with varying frequencies. We have not particularly had great improvements with any of these. We have found, we did have 2 children require both G-tube and mechanical ventilation in 2016, which was somewhat different from our population in 2014. Lots of patients requiring feeding assistance initially, some kind of respiratory support initially, but many of those being able to be weaned. There was, I don't really have much time, so I'm going to skip over this. We tried fluoxetine for a while because there was some evidence that in a test tube, it could inhibit replication of enterovirus D68. That did not seem to work in our patients. Ultimately, rehab therapies have the best benefits. And again, the problem here is getting them paid for by insurance, making sure you're going someplace where they have experience with AFM, because what I see a lot of is if my patients go someplace where there's not enough experience, they'll say things like, oh, we're not getting enough improvement, or you're not getting better fast enough. And in reality, to maintain the gains that they've had, they have to continue to get those therapies. So it's really incredibly important. E-stim, aquatherapy, being able to consider lots of different options, and for some patients, nerve transfer surgery. So basically, while that area of muscle is still relatively healthy, you can basically kind of reattach or rewire some of the input to that muscle to try to maintain some movement and some strength. There's a lot to think of there about who's an appropriate candidate. So you really need to go to a center. Shriners in Philadelphia is one of those. Children's in LA is another, who can consider that. UT Southwestern is another. So what about outcomes? So this is a new study coming out of KKI, which is one of probably the best place to go in the country for rehab if you've got AFM. So most children had some improvement over time. Distal greater than proximal recovery. Of course, this is kind of a problem in some ways, because if you can use your hand and you want to use your hand, but your shoulder's not strong enough to support you using your hand, then keeping your shoulder in that socket is not necessarily going to be the easiest thing. And also, it changes how the weight is distributed to your spinal cord, so then you're also more prone to scoliosis and things like that. Patients did, with lower extremity involvement, did tend to require mobility devices even at the time they were discharged. And they did, interestingly, see a decreased need for respiratory support over time. And also, and this is what we've seen in our patients as well, the bowel bladder symptoms do seem to resolve. Additional complications include hip dislocation, kind of again along the lines of the shoulder issue, scoliosis, and for kids that have required a lot of dental support or who aren't eating or otherwise using their mouth the way we'd like, some dental underdevelopment and occlusion issues as well. Just a brief thing about AFM surveillance, because there's always some question about, whether a diagnosis by the CDC or a case confirmation by the CDC is the same as a clinical diagnosis. And it's really not, because there are some limitations on it. So the first thing is, when we think of definitions for surveillance, we want to be as sure as we can that kind of all the patients have what we're looking for, and if there's something that's a little atypical, then maybe they're not counted as a confirmed case. Because if you want to find what the true causes are of a disorder, then you have to be sure that you're only studying people that you're really sure have the disorder. So that's part of it. And also that often when we get the data to think about these kids, we get the data from the first hospital admission. So sometimes that'll be the first week. Often it comes with a discharge summary. Usually it comes with the very first neurology note, but not necessarily good information about how that patient did or how we were thinking about it. So, and another thing there is that a lot of medical records these days are electronic. So some of the exam, and we see this even in our notes at CHOP sometimes. I feel like I'm always going back and correcting things of the exam. They default. The computer fills in the exam, and then you change anything that's not normal. So if I'm reviewing a case for AFM, and everything that's in the chart says normal tone, normal tone, normal tone, and nobody documented that patient was floppy or had decreased reflexes, because they didn't change that, then I can't confirm that case because I don't have the appropriate documentation. But with the question of does a person have AFM or not, the best person to make that diagnosis is always going to be the person's physician, not the CDC with limited information or anybody else. It's definitely a clinical diagnosis. But we are trying to improve that because we do want to be sure we're getting as many true cases as possible. So there's a lot of work ongoing to see if we can increase both the specificity and the sensitivity of the reporting system. So you'll hear more tomorrow about some of this. The AFM working group, basically it's a big group headed by Dr. Pardo of sites throughout the US that have an interest in AFM, that are seeing patients with AFM, that want to know what they should do when they get a case of AFM. We're really working on consensus recommendations, developing methods for prospective data collection. There is also a study coming out of the National Institutes of Health looking at the natural history of AFM and hoping to pick up some samples and also prospectively collected information to try to figure out, what is the best way for us to be taking care of these patients. The CAPTURE study, and of course, Dr. Greenberg's great network of studies at UT Southwestern, And then I think the other thing we're all really focused on, we've been working at CHOP with the Philadelphia Department of Health and other centers to really get information out there about AFM, especially in advance of 2018. 2017, knock on wood, it seems to be a relatively quieter year thus far. But in advance of 2018, anticipating that every 2-year spike will hold. 2020. I am so, I feel like ever since I had kids, I don't know what year it is. So anyway, and these are the reason for that. So 2020, yes. You knew what I meant, right? All right. All right. Thank you.